Ladies and gentlemen, hello and welcome. It's been a long and very exciting trip, and you guys are our second last city on this mega tour that I'm travelling with the Professor. It's been a wonderful time to be out with him at all of these different venues, and I have to say thank you to each and every one of you for coming tonight and participating. My name is John Mannis. I'm the National Sales Manager of Stratpharma, and we'd like to say hello and welcome to you, and thank you once again for coming. Allow me to set up the meeting, and I think the first thing that we need to do is introduce James and Paul from Fotona. Fotona and the Innovative Medical Technologies, who are Australia's leading independent supplier of medical and aesthetic lasers. What they try to do is enhance lives with unique non-surgical solutions right through from snoring to laser, ablative, non-ablative, IPL, RF, and also feminine rejuvenation. Fotona in itself has been around for over 50 years. IMT has been working in the field for 10. And these guys, if you would like to talk to them about the different lasers that they have, they are more than happy to speak with you at any time after the show. So Paul, thank you very much for being our co-sponsor tonight. We have some special guests. You don't get to see them, but they get to see you. So we're actually going out to Adelaide tonight, and Adelaide have a group of people, so we might be getting some questions from them during the night, and we're asking you guys to have a dynamic, interactive discussion tonight. So don't be afraid at any time to stop the Professor and ask a question. Allow me to tell you a little bit about Stratpharma. Stratpharma, with many years of international dermatologic expertise, is a Swiss company. We've developed breakthrough treatments for faster wound healing, abnormal scar prevention, and treatments that are now available in over 50 countries. Our products are designed to deliver fast results and the best overall outcome for your therapy. This means reduced recovery time so patients can return to their daily life with the best possible results. But how do they do that? Well, we'll find out. I'd like to now introduce you to Professor Leonardo Marini, who is a board-certified general surgeon and dermatologist. He currently serves as a medical and scientific director of the Skin Doctors Centre of Trieste. His academic involvement as a professor of laser dermatology has seen him teach in universities in Siena, Parma, did I get it right? Parma, Udine, and Verona. One of his recent fields of research focus has been on advanced post-treatment dressing protocols. Professor Marini is presently serving as the chairman of the Task Force for Laser Dermatology for the European Academy of Dermatology. He is proudly the founder of the European Society for Laser Dermatology, otherwise known as the ESLD. He serves on the board of many international scientific societies. Professor Marini has published numerous scientific peer-reviewed papers in international medical journals, as well as many books and chapters. He is very active in the national and international congresses, where he's delivered more than 500 clinical presentations. So for his 501st presentation, please put your hands together for Professor Leonardo Marini from Trieste.
Share with all of you in Australia my experience. This is my third time to your beautiful continent, and I feel that I'm surrounded by positive energy every time I lecture in these symposiums. So why am I here? I'm here because I like these two products. And it is not, a bias. I've been using these products since the very beginning. 5 years ago I started this Stratpharma adventure, and as a general surgeon and a dermatologist, I was at the beginning a little bit skeptical. A new dressing. What is new dressing can do? Why using a new dressing? Because all of us use already something that works. Why changing? Okay, so I started to experiment, to do it, to find out new applications, and I must say that presently I'm very satisfied. This is standard in my office right now, and I'm going to tell you why. And the other reason is, when we talk about dressing, is talking about the final part of the, let's say, procedure. So every time you start a procedure on a patient, the procedure ends when? Not when you finish the procedure. The procedure ends when the patient is completely healed. Then it's the end of the procedure. So when you start the procedure, I like to start with the good systems. And this is Fotona. I've been working with Fotona for more than 11 years. And this is a very versatile horse in my armamentarium in the office. It's a laser that allows you to cover most of the field of dermatologic surgery, and it's very versatile. Today, versatility, efficiency, and of course, reliability are the three major important categories that you may ask to an expensive system like lasers. But versatility is the most. You need to cover a lot of indication when you invest in this kind of technology. And Fotona needs to be prized for the strategy that they have. You don't need to buy a new system every time you come with a new indication. You just add a little bit of software, or you add one new scanner, and the system works fantastically well.
So you actually, with this particular Fotona laser, can do multiple procedures.
We can go from simple vaporization to resurfacing, to fraction resurfacing with the erbium. We can do a snoring treatment. We can do even endovascular treatment for leg veins insufficiency. We can do all the tightening procedure, and I'm going to discuss this later with you. And we can do a multiple-level, multi-layer protocols to rejuvenate the skin.
So, allow me to ask, is it similar to the Picosure, or is it different? And what do you think about the two lasers?
Well, Picosure is a sub-nanosecond pulse laser, which is not this one. Okay, this one is a long pulse Nd:YAG laser, so it goes very deep. You can treat vascular lesion, as I said. You can do rejuvenation. You can do even stress incontinence. You can treat with this laser, not the Nd:YAG, but the erbium YAG. But talking about picoseconds, you enter the sub-nanosecond or nanosecond range of lasers. So Fotona does a great job because they manufacture another system which is called QX Max, which is one of the most powerful Q-switch system on the market to treat not only tattoos but also to rejuvenate the skin. Like most of the people calling in the Oriental countries, they do, because they are afraid of post-inflammatory hyperpigmentation. And I developed a new multi-layer technique to remove tattoo very efficiently, so you don't need the pico, because the pico, when we talk about pico, actually, companies that manufacture pico, they have 950 picoseconds per pulse. So a Fotona laser is producing a pulse which goes from 4 to 10 nanoseconds, which is 950 pico, is almost 1 nanosecond. So there is very little difference between the two systems in terms of photoacoustic damage and photothermal damage. So let's proceed with my first presentation, which is going to be sharing. I would like to share with you my experience with laser and with Fotona laser. So the greetings from my clinic in Trieste. We have a day surgery clinic. We can perform all kind of procedure under general anesthesia and under local anesthesia. You're welcome to come to visit me anytime. So talking about lasers, how many of you use a laser in the practice today? Okay, very good. So I think that as a surgeon, I consider laser beam as an invisible scalpel. So you need to know your anatomy, you need to know the depth and you need to know the wavelength you're using, like different instruments. So modern laser dermatology is asked to treat large number of skin alteration. And since multiple alteration in the same anatomical region exists, Like, for example, we have sagging skin, we have wrinkles, we have solar lentiginous in these patients. So you need, and of course, to address many different alteration. Complex alteration, this is a classical example of a port wine stain in a more than, I think it's 55 years lady. So when we do this, it's not that we use just one pass of a pulse dye laser. We use now many different passes of different wavelength to get this. So preferably in the same treatment session. Patient want to get this, results faster as possible. Sometimes they come from far away, so we try to concentrate in one session and optimize already established procedure. This is an example of what we do now to eliminate tattoo. This is the popcorn effect. This is just to ask you a question. This is the popcorn effect you can have with a classical photoacoustic laser pass, single pass on a tattoo. This is a tattoo was pre-treated with a fractional erbium YAG laser, which is an ablative laser, to allow the gas bubble to go through immediately after. So you don't need to wait 20 minutes according to the R20 technique that was published a couple of years ago from a group of Greek doctors working with Rox Anderson. They were proposing 4 different passes with 20 minutes interval. So it will take in the whole day to do this. So what we did, we split the tattoos in 4. So we treat one part with a single pass, the second part with 2 passes, and the third part with 3 passes, and the fourth with 4 passes. What we found out was that the second pass was getting a better result than the first pass. Third was a little bit better, but not that much. The 4th didn't do anything more. So why pushing to the 4? So my protocol right now is to pre-treat the skin with a fractional laser. And then we do a full beam pass 5 minutes after. We wait 5 minutes. Why? Because every time you perform a full beam laser on a pre-treated fractional area, you have some bleeding effect. So you need to just stop the bleeding. But you can see the tattoo is clearly visible immediately. And all the gas bubbles are there. So after 5 minutes, you go to the second pass with the full beam, and this is the protocol. And you're going to see some excellent results. So we want to reduce what? Postoperative downtime, side effects, and complication, layering different wavelengths, one on top of the other, and in a sequential mode in order to allow the skin to cool down. So the bloodstream is flowing, it's 37 degrees. So if we allow the bloodstream to go through, we are giving this tissue enough time to cool.
And Professor, when you use the blast stream, do you go from the top or do you go from horizontal to the skin?
When I use what?
When you're using the blower to cool, do you go from the top or do you go from on the side?
When we use it for the patient comfort, we use the Zimmer sometimes. Are you familiar with this kind of cold, chill air? But never use it perpendicular. Because if you use it perpendicular, then you lose, energy for nothing because you are cooling down the area that you want to treat. So always have the assistant working tangentially so you can remove the heat from far away and you are not cooling down the surface. Very important when you do this. Thank you for answering that. So, advanced laser layering techniques, this is what I was talking you before, is it challenging, yet not impossible exercise. Advanced laser technology is a must. You need to understand better the light tissue interaction and the modification that you create every time you do a layering. Every time you use one layer with the laser, you alter the absorption of the second layer because the skin is completely changed. So you need to understand that. Improve medical knowledge and optimize patient information and selection. So it's a brain cell squeezing exercise if you want to combine this, but it's not impossible. So in laser procedure, in aesthetic dermatology, of course, we can use a full beam, a fractional beam, and this system here has both capabilities. So we can target the epidermis. We can target the vascular component of the dermal and subdermal skin. We can try target the pigmentary targets, And we can target also the structural dermal, hypodermal targets. And we can also try, the recent advance is we can even try to target the subcutaneous fatty targets. So we can work on both the content, which is of course the subcutaneous fat, and the container, which is the skin. So we need to have a good equilibrium between the two in order to have this kind of rejuvenation effect. So combination procedure. What we can do, this is a simple procedure. This is dermal nevomonocytic nevi. You can shave it, you do a shave biopsy, and then you can sculpt. What is the advantage of using the erbium YAG over the CO2? Erbium YAG is an invisible scalpel. So you can, this is a wavelength, is fully absorbable water. So every time you get the laser beam to hit the skin, you don't have any residual energy which is left and is able to create some thermal damage. So if you use the pure erbium YAG laser in an ablative mode, you don't create any thermal damage. You can really sculpt the skin. So this is what we can do. This is another case, simple with the, and these are difficult cases. This is an epidermal nevus syndrome. This is a young gentleman, 9 years of age. This is 15 days after the full sculpting of the neck. And of course, I didn't dare to sculpt the neck with the CO2, because with the CO2, the ablation is getting less, is more problematic the more water you subtract at each pass, because you are always having 20% of energy left after the first pass when it's responsible for the coagulation. So every time you do a second pass on something that's being coagulated, you have less water. So instead of having an efficient ablation, you have a less efficient ablation and more coagulation. So in order to sculpt the skin, you need to use this kind of laser, which gives you a very, very nice safety profile. This is the same gentleman. Unfortunately cannot cure this kind of disease. He came back at 21 years of age, and look, he was looking like this. Look at the highly movable areas around the eyes, around the mouth, where this kind of epidermal nevus is proliferating more. And this is 21 days post full face resurfacing with this erbium YAG laser. Of course, you may say, what kind of dressing you use, because this is an aggressive procedure. It's performed under general anesthesia, and it's a 3-hour procedure to do this. It's not simple. We are able to have this kind of result if we use the proper dressing after the laser. So again, in the past we were using the silicone gel, silicone film microperforated. It was very nice, but it was working well only when the silicone was in full contact with the skin. In the periocular area, the perioral area, the full contact was not there. So it was always a challenge for us. And with the advance of this full 100% contact, full leveling silicone gel, you are able to bypass all the problem. Yes, please.
What kind of laser setting have you been using? How many passes? Sorry for asking you.
Could you repeat the question as well?
Yes.
Question at the end or now?
It's okay. So, of course, multiple passes. You need to sculpt. The setting were 8 joule per centimeter square full beam, erbium YAG laser, with repetition rates of 10 hertz, yes, and you are able to sculpt. Of course, smoke evacuator, Zimmer, and under general anesthesia. You can increase the setting if you want, even to go up to 10 joule per centimeter square, and with a 4 millimeter spot size. 4 millimeter and 2 millimeter. If you have to 2 millimeter, for example, you work here and you want to eliminate this area, I go to 2 to 3 millimeter, and then at the end, when you're satisfied about everything, then you do a full beam pass with like a erbium YAG peel all over the face with the scanner in order to get a nice uniformity. Okay? Welcome. This is how the gentleman looked after the first day, the second day after treatment, third day, fourth day, and ninth day. You see, still, the first 2 days are the worst. But listen, even if we work so hard on the patient, and these are just the sign of the laser beam being performed, but look at the shiny effect. This is the silicone gel. The silicone gel is able to create an invisible film, which is able to seal everything and protect the healing process properly. Something that I was not able to get before, particularly in these difficult areas, Look at the healing process. Look at the uniformity of, let's say, healing that we were able to achieve even in difficult areas. This is why we like to use this kind of product. This is another case. This is trichoepithelioma papulosa multiplex, and in this case, we need to, of course, sculpt all over the skin. You can see this was at that time we were using a silicone film, microperforated, and this is the results in 90 days. Another case is another case like this, 90 days. But you see, at that time, we were not able, we didn't have this product. And you see, we were using this kind of strategy to make the silicone film as close as possible in a highly movable area. But you can imagine, we got the people coming to the clinic every 2 days, remove the dressing, clean, reapply the dressing, so very difficult. So, in the periorbital area, very difficult, again, with the erbium YAG, you can really get this wonderful result. And the healing is fantastic if you use this self-leveling silicone gel. Why do we use the self-leveling silicone gel? Because we want to have a full contact of a very difficult, very baby skin that is just maturing. We don't want to disturb the healing process. We want to protect with a film, which is transparent and very, very, very thin. And another quality is the pliability. It's pliable, so it follows every movement. So it's something the patient is not feel, constrained, pulling. It is fantastic. Ablative fractional beam erbium YAG laser to correct scars. This is a very, very painful scar. This lady got surgery. She got a nasty kidney tumor removed, and she developed this hypertrophic scar. She was not even able to bend because of the painful procedure. Look what we were able to obtain. This is 3 months after 5 treatment, fractional laser. Of course, using immediately after this full resurfacing protective silicone gel. Venular ectasia on the face, rosacea patients. This is using the 1064, which is the other wavelength that this laser can perform in a single session. This is 12 months post-treatment, you see. Nice results, just with the ND-YAG laser. So with this 2 wavelength, you can use it singularly now, you can have this kind of result. Another case needs more treatment. This is a veteran from the Vietnam War. I was a consultant dermatologist for one of the largest U.S. air bases in northern Italy, 20,000 U.S. Privates and officers that were coming to me. So I got the experience on every different skin types. So again, venous lake, another case that is respond very well to 1064 nanometer. This is just one treatment, you see. She went unfortunately to a plastic surgeon. She was, smart enough. The plastic surgeon proposed an excision for this. So just a single procedure with this. And again, on the lip, what kind of dressing you put? You need to put something which is transparent, is self-leveling, and is able to protect the healing process. Another venous lake. This is the result after 1 session. This is a complex cases. This is a patient that came with a virgin, never treated, port wine stain. Some blebs were here. So we were able to combine in the same treatment a 1064 long pulse laser, a pulse dye laser, an intense pulse light, and followed by ablative fractional laser erbium YAG and a full surface laser peel with the erbium YAG. This is performed under general anesthesia again, and we were able to obtain this result in just 1 session. This is one session, okay? So this is the beauty of combining different wavelengths, one on top of the other, and using the proper dressing. This is absolutely an essential exercise today. I stress that your surgery is not over until the patient is completely healed. You need to close the cycle. And to close the cycle, you need to understand the importance of the healing process and the importance to protect the healing process with the proper dressing system. Simple lentigo. This is pre-op. We use the erbium YAG, very gentle. This is 6 months post-op. Ablative fractional erbium YAG, skin remodeling for post-acne scar. This is after 90 days. And of course, you can see the importance of pre-op, post-op with no dressing. You can see the skin is very dry, tries to form a lot of, a little bit of the oozing coagulate on top. Look, post-op silicone gel dressing, much more uniform. This typical shiny aspect of what is able to self-leveling itself, creating filling all the little creases that the laser is creating. And this is fantastic. Another case, this is full being fractional erbium YAG for acne scar. She is a picker, and you can recognize the post-inflammatory hyperpigmentation 6 months after. Another, let's say, innovation in combining technologies. This is erbium YAG thermal mode, because you can use the same erbium YAG, which is able to vaporize the skin without any thermal damage, in a long pulse. If you use a long pulse, what happens? Where is the thermal surge? Is on the surface where the water is, but you're using a energy for a long amount of time, which is not reaching the temperature of vaporization, so still is creating a heat on the surface that travels in depth. So you can use this kind of laser in a thermal mode without vaporization. So the modulation of pulse is what makes this technology, laser technology, so versatile today. So this is why similar to what happens with the silicones. When we talk about silicones as a dressing, they are, not all the silicone are the same. Silicone is a polymer. It's formed of different bricks. Every brick is a monomer. So according to the length of the chain, you have a different silicones, different end result. You can have silicones as hard as this table, when the length of the chain length is very long, or you can have silicone as fluid as water when the chain is very short. So the Strat Pharma was able to analyze and to come up with the right length of silicone, which is able to create the possibility to develop a film. And on your table, you have many different silicones. You have the Stratamed and the Stratacel, which are the two silicones that are produced under sterile condition, and you can use it on open wound. I suggest you to try to put few drops on the dorsal of your hand, one with Stratamed, the other with Stratacel, and just spread it over, just to have the feeling. And then in few minutes, you will see, and John is, don't forget to put this silicone on the website, here. So you get the perception of how important it is to have a self-leveling kind of coverage for the wound. You don't need to apply more. Just distribute, have this shiny effect I show you on the picture, and in few minutes I'm going to ask you to touch again your skin, and so you have the perception of what the patient feels after that. Okay? This is a thermal biomodulation mode with 1064, which is a long pulse ND-YAG laser to create a lot of thermal effect in depth, followed by multiple sequential passes painting technique.
Professor, if I could interrupt you for a question from the floor, please.
Yes.
I'm really sorry, I probably missed it. When you did that lady's striae or whatever it was you were treating, which one of these did you put on?
I just used the Stratamed Stratacel. Stratacel and Stratamed are the two products that are from Strat Pharma, which are produced under sterile conditions. So I urge you to use, even if you can use all of them. But imagine if you have, for example, a complication, you want to be on the safe side. So these are medical devices that have been designed to apply on open wounds. And how often you apply this? As often as the patient feels. Okay. Usually, we did a study, and we measured transepidermal water loss of the skin before and after the application of Stratamed, and we measured the transepidermal water loss every 30 minutes. What we found out was that after 30 minutes, of course, the transepidermal water loss was much less. But after 3 hours, it went back to normal. So that means that the silicone film is so thin that it disintegrates, it disappears. So you need to reapply every 3 hours, okay? In a early phase of a healing process, you need to apply even more because the skin is oozing, the skin is detaching this, so you need to apply. I tell my patient, usually we give 2 or 3 tubes of this silicone after the procedure, so they are being instructed to use as many times as they want in order not to have any kind of crust forming. So this is very important. And they feel much better because this is a film-forming gel, which is reproducing the skin barrier. So you allow the skin to be in a nice condition like a normal skin. You still feel the warmth, but you don't have the extra warmth that you have when you apply something like Vaseline. Vaseline is occlusive. And when you do an occlusion, you don't allow any vapor to go through. So an inflammatory process, you get redder, and the patient starts to complain. So this is why we use that. So let me see the other part. This is a photothermal body reshaping, so we can combine the long pulse and the YAG laser, which is acting as a fat melting device, and the long pulse erbium YAG laser on top. This is we use a painting technique, and I'm going to show you how we use it. We use a painting technique for 3 to 5 minutes on small areas, and we put one small area close to the other where we want to sculpt and to modify the subepidermal fat. Why combination treatment on the face and on the body? Because, of course, on the face, hands, and the neck and décolleté, we have many multiple lesions together, as I showed you before. So when we consider a patient old for her or his age, when the patient has a lot of skin color, brown spots, and skin color non-uniformity. Of course, you have some eyes and lips volume problems and crow's feet and wrinkles. But volume, color, and resilience are the most, address characteristic that tells you that your skin is not, of course, young again. How young is the young patient? When photo and chrono aging are concerned, of course, what kind of minimally invasive laser or energy-based device procedure should be proposed? Of course, you need to understand that every patient is different. So the analysis is fundamental. You are doctors. We are not cosmeticians. We are not estheticians. So the diagnosis is the first thing. So once you understand the difference between this kind of patient, then of course you can tailor all the different wavelengths we discussed before, and you can have this kind of beautiful result. Who is aging first? Unfortunately, women. Because women, after menopause, they lose a lot of collagen. Look, 2.1% of skin collagen per year, which corresponds to 1.13 skin thickness per year during the 15 to 18 years post-menopause. So it's very important for women to start, some procedure like this to prevent this. So younger skin and older skin. The young skin, of course, we have the content and the container in a good equilibrium. The container is very elastic, so you don't see much of a transition between the cosmetic units of the face. When you get older, the skin is sagging, is very thin, is getting thinner, so we have a progressive compartmentalization of distinct facial aesthetic unit. So let's see what we can do with this system again. In this case, we did a transconjunctival lower lid blepharoplasty and a fractional full beam ablative erbium YAG laser in a 75 years lady. This is another example of the same procedure in a much younger lady. This is immediately post-op. You can see we did a full beam resurfacing here. There is a fraction resurfacing all over the face, and this is the result 30 days post-treatment. Still, you can see the difference between the two different laser paths, but look at the shining effect of this kind of beautiful full resurfacing protective gel that we use, a silicone gel, to have this recovery. This is the same patient.
Professor, just for Adelaide, so
Yes.
they get an understanding, 2 different sorts of lasers were used in different parts of the face, correct?
Yes.
Thank you.
So this is the 4 months post-treatment. You can see, look at the quality of the skin around the eye, look at the quality of the skin all over the face. This is just a single procedure. So our aim is, therefore, since a blotchy pigmentation, irregular pigmentation is recognized as one of the worst signs of aging, we need to eliminate that. So the indication, mild to moderate chrono aging, moderate to severe photoaging, and the rationale to support all this kind of layering technique is that imagine that the skin, the cells act as an intimately related member of a complex teamwork. The more cells you recruit for the anti-aging process, the better is for the final result. So again, the spot rejuvenation consists of a sequential layering of deep and superficial photothermal photoacoustic effect combined with a final pass of 15 to 20% TCA chemical peel or a full erbium YAG peel. Post-operative pain is minimal, where proper skin care is prescribed. Again, the patient is complaining because the skin dries very fast after that. So you need to preserve the water underneath without creating any maceration. If you create maceration, like using Vaseline or other kind of substances as a primary dressing, this is not correct. And you increase the chance of infection, because if you increase the temperature, not only the skin, the patient is not happy, but the bacteria are much more happy because of the temperature. I'm going to discuss this later. Why we use temperature? Because this is a study that was published recently. You can see that the collagen production increases with increased temperature. This is 45 degrees, this is 60 degrees, and you can see collagen type 1 picks up, and look at what happened after 60 degrees, it picks even more. So we need to give temperature to the fibroblasts to stimulate that. And we need to micro-wound the keratinocytes, because this is another interesting paper that was published recently in 2007 that stressed about the evidence that keratinocytes stimulate fibroblasts to synthesize growth factors, which in turn will stimulate keratinocyte proliferation in a double paracrine manner. So if you stimulate the fibroblasts underneath the skin, and you stimulate the keratinocyte on top of the skin, you have this kind of double effect. This is why we use 2 different lasers. This is an article I published some years ago using a sequential photothermal fraction resurfacing using the Nd:YAG, short pulse and long pulse, to warm up the deeper layer, and then on top, fractional ablative tissue remodeling with erbium YAG laser. This is the result we were able to obtain. Not a dramatic result like the result we were able to obtain when we're using a full face resurfacing with a CO2 laser, but the downtime and the side effects that when we show the picture to the patient before accepting this kind of procedure, they don't accept anymore. So only a few of them. It takes time for collagen to remodel. So tell the patient that they need to wait at least 180 days to get this kind of result and stabilization. This is another case of using 1064 and fractional erbium, so one after the other. Again, the skin gets better after 90 days, 3 months. So take, your time. This is the combination that was recently proposed by Fotona, is using intraoral tightening, using a special handpiece, which allows you to deliver the non-ablative thermal erbium YAG inside the skin. So you recruit the fibroblasts inside the skin. Then you use a FRAC3, which is a short pulse, 0.3 millisecond Nd:YAG laser on the outermost of the skin, of the outer layer. Then you use a long pulse Nd:YAG, and again, a superficial light peel with the erbium YAG. So erbium, Nd:YAG, Nd:YAG, and erbium. So this is an example of spot rejuvenation, combining different techniques. In this case, we have a dull skin color, blotchy pigmentation, irregular skin texture, moderate static wrinkles, and dilated pores. And can I have the video, please? Don't be impressed. So you will see how we combine all different techniques, one after the other, in the same operation. So this is the first pass of the Fotona 4D. You can see we're using this kind of glass handpiece with a reflecting mirrors that allows the beam to be reflected at 90 degrees in the mouth. This is in the long pulse Nd:YAG from outside to warm the fibroblasts from the other side of the face. And you can see this blanching here. This is a thermometer that tells you that you're working on the right temperature all the time. This is what I call spot hunting. This is using a 533 Q-switch laser, which is it's a nanosecond laser. The same laser we use to remove tattoo. When you use this laser, never use the laser at high energy. You don't want to have the purpura, in immediate use purpura. You don't see any purpura here? Very little. If you see purpura, this is delay purpura. So after a few minutes you have that. This is the right setting. If you see this immediately, the energy is too much. You have a post-inflammatory hyperpigmentation, then this is the final pass with the erbium YAG fractional resurfacing. This is full face. You can see we can layer one laser after the other without fearing to create too much thermal damage. The patient is, of course, asleep because the procedure lasts 1 hour and a half, almost 1 hour and 45 minutes. And since this procedure needs to be repeated with time, we don't want to have the patient having a bad experience during the operation and immediately after. So this is why this, and then on top, what we do an IPL. An IPL, not with the parameter we use if you use the IPL alone. We modify the parameters, and this is the final, let's say, skin uniformity pass that we use with the IPL after we treat it with the erbium YAG, with the Q-switch 532. You see, the parameters we use in this case, a double pulse, 7 millisecond pulse duration, and of course remember that when you use an IPL, every IPL is different. So I cannot give you these parameters, and please don't repeat my parameters on your IPL because every IPL, again, is different. Then we clean the coupling gel, and then after we clean the coupling gel, we wash with normal saline, and on top of this, we apply a TCA 15% chemical peel. Now this is Zimmer. Of course, it's not a TCA chemical peel that you apply on an interskin. It's an immediate, you see? It's a very fast, this is the chemical peel. Suck, very fast, because the penetration is immediate. Okay, what is why we use this? Because we want to create like a coagulative effect of the proteins on top. So we protect everything and we seal everything. And on top, of course, we use, thank you very much. This is the patient, and we seal everything with the silicone. You see the shiny effect? This is day 1, after the procedure you saw. This is, again, this is 7 days post-op. Look at the quality of the skin, you know? Nice, uniform is getting there, and no crust, no crust. This is what I like. And this is the patient 30 days post-op. This is not a patient that I took. The patient usually, this is a patient that comes from far away, send the patient the pictures she did by herself. But look at the quality of the skin. Nice quality. Just using the proper dressing. Another spot rejuvenation on the face. This is pre-op, 4 months post-op. And this picture was taken on the same patient 6 years before the procedure. Who is looking younger? This is 6 years before. Okay, so this is the technique, 1064, short pulse, deep tissue priming, or the Q switch 532 spots, 532. This is IPL. This is the optical window we use, and then we use the erbium YAG or CO2, but I prefer the erbium YAG, and on top a 15 to 20% TCA, ultra fast chemical peel finishing. There is no limit to the area we can treat. This is a décolletage, 60 days post-op, but of course the healing time is a little bit longer than on the skin. You see, this is 5 days post-op, still this kind of discoloration. Look at the shiny effect of the post-operative dressing. Very important to cover all the different creases with this kind of silicone gel. Hands, you cannot rejuvenate just the face, you need to rejuvenate the hands. We have a lot of requests about hands. This is the results we can have with a single treatment using the spot rejuvenation. Again, this is 5 days post-op. Again, it's very slow healing. You see the shiny effect? Very important to use the correct post-operative primary dressing. Another hands example, and how long this procedure will last. Look, in terms of clinical effect, this is 2 years after the procedure. 2 years, 2 years. You know, it's, if we are able to protect the skin properly, hydrate the skin, and protect it from the sun damage, we can have a nice result. So the complications are the same as any kind of resurfacing procedure. We give them oral antiviral. Of course, we give them also antibiotics. And of course, we need to select all the patients because every patient needs to have an expectation that matches what we can do. Another case, you can see we always show this picture to the patient in order for the patient to know what to expect. So day 1, day 2, the day 2 is after 48 hours is the worst day. They are much more swollen than day 5, day 6, day 7. In 7 days, they are healed. It's very important to get that. So this is the sequence we use immediately after. You see semi-permeable 100% wound contact cell laminated silicone gel to be reapplied every 3 hours. This is our recommendation, but we tell our patient to put the silicone Stratamed in this case, because in this case we didn't do a fraction resurfacing. This was a spot rejuvenation without fraction resurfacing. We want to have the patient comfortable during this first 7 days of the healing phase. Skin cleansing with gentle antiseptic solution, followed by short contact acetic acid solution, which is 2 tablespoons of white vinegar in 1 liter of normal saline twice a day to prevent Pseudomonas infection. In other cases, you can see, and thank you for your kind attention. And I'd like to invite you to this meeting we organize in Trieste every 2 years. It's a cyber meeting. You can participate even staying in Brisbane. The meeting is available on the web. All the meeting is recorded. So all the presentation, including the question and answer and the discussion, is recorded. You can get access to every single presenter of this meeting for the duration of 1 year. The meeting in Trieste is very small. It's very, I want to keep it small, like a boutique meeting, maximum 400 per participant, because I trust that this small meeting allows a better interaction with everybody. Yes?
So, Professor, I now open it up to the room, including Adelaide. Does anyone here have any questions that you'd like to ask concerning? Yes.
The lasers are inside the lip there on the mucosa.
Yes.
Is that correct? What's the object of that?
The object of that is to recruit as many fibroblasts as possible in this kind of layer, in this kind of thickness of the skin. So as I said before, the more cell you recruit, the better result you're going to have for the remodeling and tightening effect of the container, which is the skin. So if you use just the external approach, the maximum depth you can go is, let's say, 8 millimeter, 10 millimeter, which is, of course, the Nd:YAG laser wavelength. But if you go from inside, then you can recruit more cells which are in depth, and you're not able to recruit. At the same time, you are always able to create a kind of pulling effect of the lips and the other parts of the perioral area. And this adds to the beneficial effect of the layering technique I told you before. So this is a new advance. The same parameters we use, for example, in the vaginal rejuvenation or in the treatment of stress incontinence. So the same non-ablative thermal parameters are able to produce these kind of results.
So you do that on the upper lip as well?
Yeah, yeah.
With regards, Doctor, to the use of that particular end piece, do you find that the patient finds it uncomfortable in any way, or the heat from the inside of the mouth?
No, they don't feel it. We use a little bit of lidocaine spray, which is the same the dentist uses before giving the injection, so they don't feel anything. And we do 6 passes with this. And since the glass it's dome, there is a dome of glass which is absolutely non-aggressive to the anatomy of the inner oral anatomy, you can really resurface without any problem all the areas. So this is a nice advance, and it's easy to apply. You just use this accessory on what is already existing on this kind of laser.
Question from the floor, please.
You say that Stratamed and Stratacel are sterile, but as soon as you open it, it's not.
It is sterile in medical legal issues. So everything is sterile, okay, because nothing grows in silicone, as nothing grows in Vaseline. So we can consider this sterile. But in case of a medical legal litigation, you open up and you apply something which is, marketing as sterile. So you're protected. But in theory, you can apply all these silicones on top of the skin and without any problem. But in case you have an infection, not because of the silicone, but because you have an infection for other reasons, and you apply something which was marketing not as sterile, then you may be in court, since you need to report where you apply, say, hey, but you apply something that was not sterile. The judge doesn't know anything about it, so you are in easy prey to this. So this is why I'm using that.
I'm more concerned with the actual wound, say for excising a skin cancer.
Yes.
And in the old nomenclature, you used to put on a waterproof dressing for whatever.
Yes.
If you then give the patient some Stratamed, then by definition they don't know sterility, and the thing is not then covered with a waterproof dressing.
Well,
so what would you suggest?
In skin cancer surgery, since I don't trust my patient, the Italian patient are the worst, I cover my surgical scar and I leave the dressing on until I see them for follow-up. They don't change anything. So it's a dressing I said to my patient is an integral part of surgery. Don't touch it. So I put Stratamed or Stratacel on the wound, and then I put some epidermal glue, which is mastisol, and Sterastrip, like a bridge. And you will see the video. You want to see the video right now?
Would you like to do
Yes,
the
why
video?
not? Yes.
Okay.
We can see the video. So you can see how I use it. This is the surgical excision B, video B. So you'll see how we apply. And of course, the healing time is different. The face heals faster, so 7 days. So we'll see. Usually, I don't give any external suture in fusiform excision. All absorbable sutures, and I use the suture.
I start the dressing with Stratamed. Okay. I apply
this
it,
is
then
Nino
do
Benedetto voice.
an occlusive dressing gauze dressing over the resected margins, over the wound itself, and then I have the patients change it on a daily basis. But the value of Stratamed is that it doesn't interfere with the secondary dressing. You apply Stratamed like you would do any other kind of topical antibiotic, and it doesn't combat or it doesn't prevent an additional dressing for protection during the really important post-operative period.
So Leonardo, here we're seeing that you've just applied the Stratamed directly and you're not waiting for that to dry? So it's not taking any extra downtime or?
Absolutely no, because as you can see, I can put the Sterastrip on top like a bridge. So the dry area is the periphery of the Stratamed, and I like the Stratamed to stay as it is because it's a fresh wound. I like to have, and my technique, I leave this for 7 days untouched.
So, then I cover with the regular dressing. If it's oozing, I use a alginate strip, and then some cellulose, absorbing to create extra pressure. Cover with the tape. Don't touch it.
I should address this to you, John. The $12 a tube. It's not a big amount, but once you've used it once, you've used it once. You can't reuse it on the next patient. So it's a 5 gram tube.
So what
I'm suggesting is you should put it out in 1 ml little containers.
Exciting things to come for the future. We I'm sure, and talking in school here, I suppose it's a closed. No one's listening, are they? We will be having a look at other options in the future. But for now, what we say is that this 5 gram tube is perfect because whilst it can be used during that time when the secondary wound dressing is on, and you don't have to reapply it. The patient during that early phase of reepithelialisation, inflammatory phases, and moving into that remodelling and maturation phase, you still need to use the silicone for a period of time because if you have skin like mine, you might not scar immediately. You might scar a little bit later on. And so what we suggest is that you would use the Stratamed for at least 60 to 90 days. And that 5 gram tube will cover a 2 to 4 centimetre scar quite nicely. And what's left over can go into a cupboard or in the fridge and can be used for burns, cuts and other grazes. And for my little girl, I even use it on her nappy rash without any problems at all. What do you think about that, Leonardo?
Absolutely. So, we have many concerns about sterility here. But as a derm surgeons, we are working in a semi-sterile environment. So we are not in open heart surgery. We're not abdominal surgeon. So we are not exposing anything. So as I said before, in our practice, we have Stratamed tubes and Stratacel tube. And our nurses, they don't touch the wound. They just have a few drops, as you saw, and then we just tape it, and it's fine. Nothing grows there, And our environment is clean. It's not sterile because we don't have a sterile. But if we use, for example, an antibiotic ointment, we use the antibiotic ointment for many patients, and we tap again. So the same concept. If you want to be extra sure. And you give it the 5 cc. You use the 5 cc Stratamed. You cup the Stratamed and you give this to the patient for the follow-up and when she applies this at home. So this is to be extra precise. But in practice, I don't do this. I don't do this. For a full face resurfacing or for vast areas, we give it 1, 2, 3 tubes to the patient to reapply at home as many times they want. It's part of the treatment. Okay. Now, can I have the first presentation of...
So, any other questions before we move on from the laser resurfacing part of the talk? No?
Yes.
One more. Please, just down the front, question from the floor.
How about skin grafts after skin cancer surgery? Do you apply similar
Yes.
dressing? Yeah.
Yes. So no limitation to the application. You can do everywhere you want. So if you want to have a demonstration, I'm going to, since you have glasses there, and these glasses are not, you know, a gift, but just please take it back there. So, as we said, the most difficult areas are here, the most difficult area is here for the healing, and this crease is here. So this is why I like to use this kind of dressing as you show. You can see how we apply, it's very simple, and look the shiny effect that we can have. It's beautiful. You don't need much, you see? This is similar to what we did. So it's self-leveling. It's just when you have a new floor and you ask, you know, the workers to come in your home, they have this kind of self-leveling cement. They pour it, they don't touch it, it's self-leveling. This is self-leveling silicone. It is really a step forward in terms of the full contact barrier protection or barrier mimicking protective film, which is preventing any kind of, yes? Thank you. Now, since you tried before, touch your hand. You forgot it. What happened to your hand? You feel anything? Nothing. It's just to have a second skin. So this is the beauty of that. It's not pulling at all. So it's following all the movement of the skin, stretching, relaxing, everything. So this is the beauty of the dressing. So since we have the luck to have the system here.
So ladies and gentlemen, whilst we allow Professor Marini to set up, I would like to ask the doors to be closed for the laser. Oh, we will. Do we have time to bring the mains in quickly,
Yes,
Professor?
yes, sure.
Please. So as we bring the mains in quickly, I'll just ask that everyone grab their protective glasses. And one of the important things, and I do need to mention this, that Fotona has been very kind to provide us with the glasses, but we've got one big tour to do in Sydney, so we need them back. So Paul and James will be running around and asking you to hand them back to us, so the lovely people in Sydney have a chance to go ahead and use. Now, very quickly, whilst we are setting up the actual machine, I'd like to ask Professor Marini just to grab this pink piece of paper and just see how much actual strata has been on the hand.
So, for example, this is Vaseline. Something that was in the States was very extensively used on wounds. If you use Vaseline, if you touch, look, you know, this is greasy, it's messy. Usually we don't use pure Vaseline, but we use a combination of spring thermal water plus Vaseline. But on top of, even if we try to dilute, still it's occlusive. If we use, for example, the Stratamed, you see almost nothing is there after 4 minutes.
I've actually got some on my hand.
Okay. Nothing. So it becomes an integral part of the skin. This is the advantage of that. Excellent. Yes. Now, we have a fractional, a marvelous fractional scanner that I'm going to use on an eggplant, the best patient possible. Okay. And
Paul, would you mind getting the door?
you see, it's very easy to adjust. And the camera, you see how precise I'm able to be with the fractional laser. Erbium YAG. This is an ablative fractional, which is very good to resurface the skin in combination with the other technique I showed you before. Now that I've finished to perform this, did I increase or decrease the surface of the skin after the fractional? Increase. So I increase the surface because I drill many holes. If I put a self-leveling silicone on top, do I need to put more or less? More, because it needs to go in all the different holes and have this kind of shiny effect. This is the only dressing that allows you to go like that, because it's able to resurface everything. And again, you will see some other video clip after that. Thank you. Where I apply liberally a lot of silicone at the end of the procedure, just because we have much irregularities. Okay? Now, we can go.
So now you're about to change the head. What's the difference and what's the benefit of changing the head here?
You see, now I'm going to remove this beautiful fractional scanner, and I'm going to use a full beam handpiece to sculpt the eggplants. I go back here, I go to skin resurfacing, and I go to sculpting 6, I go 10 hertz, 5 millimeters, and you will see with this I can sculpt the skin very nicely. See how handy is the touch screen of this laser? It's really fantastic. You see, I'm able to remove, very precise layer of the eggplant and without any thermal damage at all. So this is the beauty of this wonderful laser. And on top of this, put it over here, just a drop.
Just a drop.
Yes, that's it. This is Stratacel. Stratacel is a silicone formula that Strat Pharma made it for me. Because I like Stratamed, but Stratamed was not enough when I did a full face resurfacing, very aggressive. I needed to have something which lasts longer. You see, it's much, still semi-permeable, but it's very much more consistent. So you have a longer duration of the protecting effect. So the patient apply this less often than Stratamed. See, very nice. Okay, after this brief presentation and where you can see how versatile this system is, I'm going to proceed with the further presentation about the silicone dressing.
Well, at that note, we can take off our glasses.
Yes? They were looking good on you, anyway.
So as we set up for the next section of the presentation, Professor Marini, I take it that one of the things that you talk about quite a bit is the idea of having something that is bacteriostatic, that's full contact. And you've alluded to not having it as a micro topography, but actually the micro topography of the skin, which is a critical thing.
Absolutely correct. So we want to be always on the safe side when we perform this kind of procedure. So we want to avoid any possible infection. And every time, and I'm going to show you how important is even in inflammatory skin disease, I try to use this barrier reforming, let's say, product on chronic inflammatory process, because if you protect the epidermis, you heal faster. So for example, if you have a chronic eczematous perioral dermatitis, you apply a Vaseline. What happened? You getting better or worse? Worse. Why? Because you increase the temperature. If you increase the temperature, you allow all the bacteria that are, in your mouth to go and proliferate under this you give all the possibility for them to proliferate faster. If you use a semi-permeable, film forming, barrier mimicking substance like the formulation like the Stratamed or Stratacel, then you are able to get a faster result. And this is bacteriostatic because of this specific characteristics.
So you also need something that is inert. How important is it to have something that is gas permeable as well and mimic the skin? Is that important for you?
It is a fundamental importance because the skin works fine under certain kind of conditions. If you are able to keep this kind of condition even in an environment that you or an accident modify, and you're able to recreate this barrier artificially, even for 1 hour, 2 hours, and then you are able to reproduce and repeat it, this is the best healing you can give to your patient. Faster, more effective, and less prone to infection, as we discussed before.
So being gas permeable, does it allow too much water to escape and does it then provide a negative impact?
This is the idea, this is the beauty of this product, because the semi-permeability is just a normal barrier mimicking function. So that means that the transepidermal water loss is the same that you have with a regular skin. So this is very important to keep the healing process protected. So all the cytokines, all the cells that are struggling to resurface and repair the skin under this kind of film are working not disturbed. This is first not disturb. Allow the process to work nicely. If you clean with aggressive hydrogen peroxide, all the disinfectant, you remove all these substances. And you, instead of doing good to the healing process, you are doing bad. Then on top you put maybe an oil, which is non-permeable. You put Vaseline, or you put an antibiotic ointment. You create and increase the temperature. You are not doing very good to the healing process.
So what you're talking about as we lead into the next part of the presentation is what is an ideal wound dressing?
Exactly. May I have my presentation, the first one? Thank you. Okay. So advanced silicone history and rationale. So imagine we have an intact skin. We do a dermatologic laser procedure, like the one I just described, and this is halfway to the end result. The full result is only when the full wound healing process is again concluded. So we need to have a faster recovery of functional skin homeostasis. Presently, there is no single primary dressing which is able to adapt dynamically to all the three phases of the wound healing process: the inflammation, proliferation, maturation. During the inflammatory phase, we have a variable oozing according to the wounding effect we did. In the proliferative phase, we have light or no oozing, remodeling phase, no oozing. So the dressing characteristic for the first phase should be protective, absorbing, bacteriostatic, and the other protective, moisture-retaining, bacteriostatic primary dressing, and anti-inflammatory, anti-angiogenic, humectant, high SPF protective products for the remodeling phase. I don't want to indulge on describing the first phase of the inflammatory process, just to say, just for you to understand that the macroscopic skin barrier temporal impairment gives redness, swelling, oozing, irritated discomfort, itching, and warm feeling. And a microscopic skin barrier temporal impairment, if, for example, you do a non-ablative procedure or a chemical peel, you have redness, swelling, irritated discomfort, itching, warm feeling. So you can increase redness, you can increase itching and warm feeling if you use the wrong post-operative dressing.
So, Professor, you talk about wound dressings, but this is the thing. Everybody here has the perfect wound dressing in their drawer, and they say, we've got it. So what are you looking for that would, at this point, make it something different for you?
The major difference is the patient perception. So when the patient feels that she feels or he feels as if nothing happened after a procedure, after a chemical peel. Imagine this patient are coming back to your office on a regular basis. because we are aging constantly. So the anti-aging, treatment is a constant treatment which is tailored to every patient. If you give a patient a nice result, but the patient has a very problematic, long healing time, she or he say, okay, it was nice, but I don't do anymore. So you need to concentrate on all the strategies possible to get this patient in a very nice, smooth healing process. And this is why I like this product. Because with no other products I tried before, I was able to achieve that. And my patient love it. After any kind of procedure, it's amazing to see how after, for example, fractional radiofrequency for stria, and we have the video clip, they feel immediately after this itching, this kind of burning sensation. You protect the skin barrier with the Stratamed immediately, and after a few minutes, the patient is again almost normal.
So this dressing is like a barrier.
It's like a barrier. It's a barrier mimicking, yes, which is a fantastic, let's say, goal for us to have. If you are able to reproduce the barrier as the original barrier is, so the healing process, the patient comfort is perfect. May I have the other presentation? Yes, okay. So the primary dressing in this kind of inflammatory phase, again, should be biocompatible. And we give or antiviral, antibacterial, or antihistamine, steroid, pain control medication if needed in this phase. The second, in proliferative phase, we have a lot of different strategies, humectant, occlusive, emollient, and so on. So the task is protect, and I stress always protect the epidermal barrier, facilitate control cell proliferation, gentle topical medicated copper zinc cleansing we always prescribe, biocompatible semi-permeable primary dressing as we discussed, and springtime water plus humectant, emollient, moisturizer. In this proliferative phase, which usually starts after the first week of the healing process on the face, the silicone is not a moisturizer. So silicone dressing is a barrier-forming film, which is very, very similar to what we have on a normal skin. But at that time, patients need to have extra moisturizer. So when you imagine now that you put this, it's completely dry. It's dry on the surface, but it's not completely dry underneath. On top of this, you can apply a moisturizer, a cream. When the silicone is dry, you can put a moisturizer on top without any fearing of, so actually the duration of the protecting effect is much more prolonged than using the silicone alone. So this is the beauty of this kind of stratification of effect.
So you would actually use the Strata product,
yes,
followed by a moisturiser, sunscreen. We're in Australia, so sunscreen.
Yes.
Makeup.
Yes, everything. Everything on top, because I already protected the barrier. So I'm not afraid. I have the protected barrier by this invisible, very thin, self-leveling, 100% contact silicone, a barrier mimicking dressing, or let's say protection, okay? So if you want to apply an active during the proliferative phase because you want to prevent a hypertrophic scar and you want to use a steroid, a clobetasol, for example, a poster treatment 2 days in a row or 3 days in a row for following the 4 weeks following the healing process. When you apply this steroid, before or after Stratamed or the Stratacel? You put before or after? No, before. Because you put before because the active needs to be absorbed by the weak epidermis, which is a baby epidermis, very thin, is not able to retain water because the corneal layer is very thin. So I take advantage of this weak epidermis to allow the active to penetrate. So I apply the corticosteroid first. I allow the steroid to act for 2 or 3, 4 minutes, and then on top I put the barrier.
But if it's semi-permeable, surely the time will go through.
So the question is, if it's semi-permeable, surely the cortisone steroid will go through.
Yes, but it's semi-permeable, but exactly. So it's very important to don't use anything that interferes with the penetration of the actives. So this is the take-home message. So sometimes we use also imiquimod, which is an off-label use to prevent, the hypertrophic scar. We use 4 days in a row imiquimod at bedtime and 3 days in a row steroid, okay, twice a day. Imiquimod only at bedtime. Never use imiquimod on open wound. Never, because you have an ulceration. So you put this, and then after 2 or 3 minutes, the Strata family, the Stratamed, Stratacel, or in case we still have some little, kind of weaknesses, or you can move easily to the Strataderm, which is the other product from the family, which is not sterile, still sterile, to cover. And on top, you use the moisturizer or the sun protection. Okay? Okay. During the remodeling phase, which is sometimes problematic, is particularly if you have been very aggressive, again, gentle topical cleansing, spring thermal water, humectant emollient moisturizer, anti-angiogenic, anti-inflammatory topical preparation. And if you want to protect that, to give it extra protection, you can put a little film of this Strata Derm. So, example of primary dressing, why we use occlusive dressing? Because occlusive dressing, and we are far backward in history here, this is not occlusive, but I'm not telling you anything new, less painful, tender, swollen, and red. That's open dressing strategies, because open dressing, you allow the wound to be exposed to the environment. You're not in control. This is why it's working. So this is what kind of primary dressing we can use. This is a hydrocolloid that we always use, an extra thin hydrocolloid. What are the differences? It's relatively difficult to application because you need to cut according to the anatomical area you want to resurface, partial adherence to complex anatomical areas. Dressing change frequency depend on the moisture absorbing capacity, and you know that these products have a very short capacity, very limited capacity. They need to be changed very often when we have a lot of oozing, and relatively laborious and sometimes uncomfortable for the dressing change. And more of the most difficult, the most challenging is the allergic reaction. Remember that this dressing contains carboxymethylcellulose. Carboxymethylcellulose has been known as a possible, substance that creates allergic reaction. And these are examples of allergic reaction of caused by this kind of primary dressing formed by this carboxycellulose in my wounds. I never want to have this kind of reaction on a cosmetic patient. So this is why I don't use it anymore. This is an example of the microperforated silicone gel I showed you before. These are very nice in areas where we have full contact, but here, and here, we didn't have full contact. So difficult application, partial adherence, dressing change every 2 days, long and laborious dressing change procedure, uncomfortable experience for patient, and I would say also for the nurse responsible. I'm not telling you anything new about the semi-permeable silicone gel as a primary dressing. As I said before, we have the silicones are formed by many different, the same bricks, multiply along a chain. So according to the length of the chain, we have a different kind of result. The early use were for burns, keloids, skin graft, and this is an article that was published in Burns many years ago. And this article said that, the full potential of gel is probably not yet realized as newer uses are continually being developed. And we're talking about just silicone gel without any kind of study about the length of the chain. They already got the information at that time.
So what's important about the length of the chain of the the Strata products that you like?
So the length of the chain is important because if we have the correct length, the chain interwoven together in order to create this kind of, let's say, semi-permeable effect. Otherwise, if they are too long, if it's very difficult, they pile on top one of the other, and we have a less permeable, a semi-permeable effect. We have an occlusive effect, so we don't want that. So this is the beauty, and this is why the Strat Pharma was so good in researching this kind of length of chain, which makes a complete difference with all the other silicones we have on the market. Let me see the other slides. Again, there's a lot of literature about the prevention of hypertrophic scarring keloids, silicone as primary dressing, medical literature, again, what we can have. So what is the characteristic of an ideal primary dressing according to what we discussed tonight? Sterile, bacteriostatic, transparent, odorless, and rapidly self-drying, biologically inert, structurally and biologically stable in physiologic environmental condition, easy and painless to apply and remove, absolutely fantastic and important in a cosmetic procedure, excellent flexibility and adaptability to all kinds of wound surfaces, full contact, epidermal barrier mimicking persistent protection of healing tissue, as we discussed before, effective reduction of acute inflammatory symptoms, burning, itching, and sign, redness, discoloration, because the skin is protected, it's being kind of pampered by the dressing itself after the injury. Semi-permeable, which means gas permeable at physiologic, non-macerative, moist retentive. So if the permeability is less effective, then you allow a lot of, let's say, water to to accumulate underneath, and you have a macerative effect. So you don't want to macerate the surface. You want the gas to go through freely. Aesthetically acceptable, chemically and mechanically compatible with secondary dressing. As we discussed, we can put on top of this, once it's dry, all kind of secondary dressing, relatively inexpensive, and prolonged shelf life. So I think Strataderm and Stratamed, they have all this quality, and Stratacel, the new baby in the family, as well. So protected cell silicone-based semi-permeable gel formula are medical devices. I'm talking Stratamed and Stratacel. They can be used on open wound and barrier-compromised skin in any kind of procedure and any kind of wounds. This is the patient that you saw before. Imagine how irregular is the surface. This is just a drawing of that resemble, mimic what we were able to create in microscopically on the surface. Now, if I stretch this surface, I have a longer line. So this is why I need more product to be applied on top immediately after the surgery. Skin surface during the second day, still we have a lot of irregularities. We have swelling. So again, we need a lot of products to fill all the gaps. And then when the patient is healed, the surface is flat, we have less products.
So, Doctor, you seem to be creating a moist wound environment, but what's happening to the keratinocytes underneath that particular dressing?
Of course, they migrate, and they are happy to migrate in this kind of environment. So they resurfacing, they move much smoothly in this kind of environment. If you have a dry environment, they are struggling to move. So we have crust forming. The crust creates an obstacle to the migration of the keratinocytes. This is why it's so important to have this kind of dressing on.
Slower healing with dry, faster healing with moist.
Absolutely, yes. Let's see. So we did this a split phase study. This is a CO2 fractional, 2 passes. And we measured, this side was treated with semi-permeable silicone gel, Stratamed at this time. This was treated with thermal water, spring thermal water, and white petrolatum. Look what happened. We measured the hemoglobin variation after the application of silicone gel and after the application of this combination of spring thermal water and white petrolatum. Look what happened. The irritation, the hemoglobin content that this system, which is Antera 3D, was able to register much less. Why? Because we allow the temperature cool and the surface of the skin to cool thanks to the semi-permeable effect of the dressing. Here we were almost at the same level or even more because the Vaseline was occlusive. So the temperature was not able to get chill or cool after this kind of dressing strategy. So much more uniform microtexture improvement with excellent soothing effect because it's self-leveling. You can see this is before and after. And less uniform microtexture improvement, sufficient soothing effect with the Vaseline. See, the surface is much more uniform after the application of this kind of dressing. And Stratacel, spring thermal water, white petrolatum, more uniform microtextural improvement on delicate areas, particularly around the eyes. You can see here, this is spring thermal water, sufficient soothing effect, but much more, let's say, irregular surface. In other patients, excellent soothing effect, and the indication of to use this silicone gel, any exposed non-infected wound surface, if it's infected, never use that because, of course, you are protecting not only yourself but also the bacteria. Delay superficial intermediate depth chemical assisted resurfacing, cold steel surgery, as I show you before, contact thermal skin damage, first and second degree burn radiotherapy induced radiodermatitis. The benefits, reduce redness and discoloration, as I show you before, relieve itching and discomfort, which are linked to the exposure of the wounded surface to the environment, reduce wound healing complications. Okay, I like to have my second.
So very quickly, any questions regarding this section from the floor?
Please.
So any issues about using Stratamed in acne-prone skin?
Of course, in active acne, what we use if we have a topical aggressive treatment that dries the skin. So the patients, usually I notice most of my colleagues, they use this product without using any moisturizer after that. So after 1 week, the patient call the nurse, hey, I cannot apply anymore because my skin is inflamed or my skin is pulling too much. So in order to avoid that, you can apply a little bit of Stratamed after. So the same concept we discussed before with the steroid to prevent the post-inflammatory hyperpigmentation or hypertrophic scar. So you allow the active acne protocol medication on top for 2, 3, 4 minutes. And when the patient starts to feel a little bit of pulling effect, this is the time to apply maybe a little bit of spring thermal water, a mist of spring thermal water, and because the skin is dehydrated. And then on top, you can put a little bit of Stratamed. And after 2 or 3 minutes, a moisturizer. So this will prevent patient to call your nurse and to interrupt the treatment that you are just starting to have some benefit. We all know the active acne patient, they need time to get some benefit after the topical treatment. But sometimes they interrupt the treatment because we are too aggressive. The treatment is too aggressive on them. So you need to combine with this. Okay? Can I see?
Any other questions before we move on? No? Please, Professor.
Okay, this is the same I said before. So, as dermatologists or dermatology surgeon, we perform not only laser, but we perform cold steel, mechanical, dermabrasion, needling, chemical, wounding, superficial, medium depth, deep chemical pills, thermal with a plus, thermal with a minus, cryosurgery, electrosurgery. But also, we look after all sorts of acute and chronic wounds, cuts, abrasion, incision, laceration, or whatever. So, wound healing, as I said, is a complex process. It depends on depth, size, and anatomical location of the defect, and the wound healing agent, intrinsic biomechanical properties, or biological behavior of each patient. So, of course, the face heals faster than the feet, and it goes without saying. So we need to discuss with the patient, and usually when we have a dressing on after surgical procedure on the leg, I allow the dressing to stay more than 10 to 12 days. And I always prescribe supported stockings, because I don't want, even in a small excision, I don't want any edema to interfere with the healing process. And they go to sleep or with the supporting stockings for 48 hours, and then they wear them during the daytime. On the face, what are the most problematic healing areas to here? I mean, the more delicate, the periocular and the perioral. So this is the case we did before. You will see on one side, the other side. We took all the measurements in different time after the healing, after the procedure, and look at what the patient perception was. Pleasant appearance immediately after surgery, yes, because it's transparent. After 7 days, even more. After 21 days, at that time, we didn't apply anything else that's Stratamed or Stratacel. Of course, they were happy, but not that happy because this is not a moisturizer. On top of this, they need a moisturizer. This is why we have only 2+. Easy to apply and remove, always. Non-irritant to the skin, always. Improve skin texture, yes. Again, on the 21 days, using just Stratamed or Stratacel, not much, because the skin was too dry. You needed to apply a moisturizer on top of this. And protective protection, yes, during the first healing phase, yes. After that, you need to apply a moisturizer. Common surgical lesion, look at here, this is the scar. This is a typical fusiform excision. In this case, this is a post-Mohs surgery reconstruction. In this case, we give them some external stitches. This is post full thickness incision, no suture except for Stratacel surface glue. And this is the Stratamed immediately apply as I showed you before. This is Stratamed is delayed after surgical dressing. We just removed the dressing, you see, after, in this case, 10 days. This is the print, the footprint of the dressing. And you can see this is immediately after the procedure. This is after the dressing removal. And this is when the 30 days after the procedure. Still in remodeling phase, but you see very, very nice healing process.
So there, Doctor, would you continue with the Stratamed or Stratacel, or would you move to a different sort of silicone at that point?
This is a good question. If I give my patients 1 tube of Stratamed, and they still have the Stratamed at home, they continue with Stratamed until it's over. If they finish Stratamed, while using Stratamed, I use Strataderm, which is, sterile silicone gel. So again, if they are fully equipped and they still have some Stratamed, they continue with the Stratamed. Otherwise, when they finish, I turn to the Strataderm. Okay? So this is a surgical lesion. This is a post-partial thickness distraction, cryocurettage, shave, and erbium resurfacing. All these wounds can be resurfaced with this kind of gel. This is a solo lentago that was treated with the 532 Q-switch laser. This is a multiple pass. This is a lesion that's healed fantastically well with the application of this product. This is not my picture, not my study. This was 5 weeks after Stratamed. This is Nino Benedetto. This is a 90 years patient that's 2 years non-healing ulceration after Mohs surgery on the skull. He used Stratamed and he got this kind of result 5 weeks after. This is another kind of patient 4 weeks after. This is the importance of using the correct protection of the barrier in the healing process. Again, surgical lesion. This is a fractional 1064 Q-switch laser to treat tattoos. This is a fractional CO2, fractional erbium. Perfect dressing for this. This is the patient you saw before.
And in this instance, and this is a good chance to discuss very quickly the reason why you were looking at Stratacel and how Stratacel came about in terms of something which is more occlusive or less occlusive?
No, the occlusiveness is the same. The consistency is different. So Stratacel is a dressing that I needed to have when I was treating aggressively acne patient, for example. Resurfacing acne patient. So I need something that was more consistent to last a little bit longer than Stratamed. So this is why I contacted Strat Pharma, and we discussed about the formula, and they were able to give me this a little bit different length of chain, which is still semi-permeable and is able to resurface and keep the protecting effect a little bit longer. This is much more comfortable for the patient because instead of applying every hour, the Stratamed, they were able to apply every 2 hours or every 3 hours, the Stratacel. Can I have the other yes, pictures? You can see the healing process. The patient, I think that we can interrupt this because you already saw this in the Photona presentation. May I have the last presentation, which is a new indication? And this is when you like something and you understand how this dressing, primary dressing, which in my opinion is not only a primary dressing, is a barrier protection that we are having here. So with this in mind, I thought, why don't I apply this kind of substance, this product, on chronic inflammatory skin disease? Can I see this new indication? These are just thoughts, tips, and insight, okay? So again, we have a normal skin. We have, in this case, not a surgical procedure, but we have an inflammatory skin barrier alteration. And of course, we want to protect, reconstitute the barrier function to get a faster recovery and a functional skin homeostasis. This is the eczematous cheilitis that I was talking to you before. If you give Vaseline on this patient, it's not good at all. You make this situation worse because you increase the temperature. This is the results we got 3 weeks after class 3 topical steroid twice a day, pulse therapy, 3 consecutive days per week, followed by Stratamed, 1 application every hour or as needed around the mouth. So it facilitates, modify really the environment to the extent that we have a faster healing process. This is an eczematous cheilitis. I put this patient in a gluten and lactose-free diet. Sometimes I found out that it's very, very beneficial to this kind of patients. And again, class 3 topical steroid twice a day, pulse therapy, 3 consecutive days per week, 1 application every hour or as needed, and 3 weeks. Look at this. So very nice results. Angular cheilitis, also difficult, okay? This is the same, class 2 topical steroid plus isoconazole twice a day, continuous therapy, 4 consecutive days, 1 application every hour or as needed. We got this kind of result. Psoriasis. Of course, I don't say that this is to treat psoriasis and heal psoriasis, but what happened to the skin barrier in a psoriatic patient? It's always open. It's not working. So it's constantly irritated. So this is the patient before the treatment. This is the patient 4 weeks using calcipotriol. So I use the same treatment I usually use on psoriatic patient and steroid plus Strata XRT. Strata XRT is very similar to Stratacel. As a matter of fact, before having the opportunity to have Stratacel, I worked with Strata XRT. That was originally developed to treat radiodermatitis. And radiodermatitis is very similar to a atrophic, let's say, stretch mark, because the skin is very thin. So the epidermis is not keeping any water in it. So it evaporates. It's always irritated. If you protect with a proper, barrier reforming film, that you got a better result. Look at the result 4 weeks after. Look at the quality of the skin. Just using the protocol that I use for psoriasis, but I was not able to get this result without this kind of combination treatment. See? 4 weeks after. Atopic dermatitis. Again, I'm not saying that I treat atopic dermatitis with this kind of barrier protection, but I can have an improvement. See, in this case, class 3 topical steroid twice a day, pulse therapy, 3 consecutive days per week, plus pimecrolimus, 4 consecutive days per week, plus Strata XRT. Okay, 1 application twice a day. This is 4 weeks after the treatment. So again, with this kind of images in your mind, it's not that I like you to try, but I like you to think. The importance of thinking about the skin barrier. And in modern literature about the treatment of atopic dermatitis, we know the importance of the skin barrier function. If we are able to help the skin barrier to recover with something simple, which is not aggressive, film forming, which is able to keep the right moist on the surface, we are able to have a much better result, much faster control. The patient is much prone to follow your indication. Sometimes the patient say, doctor, I feel better, but it's very irritant. Pimecrolimus, tacrolimus, you know, I start to itch. It's irritant because the barrier is not working. If you give the right protection to the barrier with this simple but yet effective device, you can have a better result. On top of this, when it's dry, you can use a moisturizer. Remember, it's like a normal skin because the surface is dry. You still have a dry surface on it. You can put on top of this dry silicone any kind of moisturizer. You can always, or you can even use a spring thermal water mist and on top a moisturizer. Don't allow the spring thermal water to evaporate. This is wrong. You need to mist and then immediately trap the water on the skin so you have a nice moisturizing effect.
Doctor, a question has come from Adelaide,
Yes.
and the question is concerning the TCA peel. Is Stratacel going to be a good dressing post-TCA, and if so, why?
Of course, any kind of barrier disturbance after chemical peel, after, let's say, non-invasive thermal tightening effect with the Nd:YAG laser, you know, the skin is a little bit, the skin barrier is a little bit weakened. So why using that? Because I want to optimize, I want to avoid the post-peel feeling that the patient has, which is a pulling effect, is kind of, let's say, a reddening effect, so because I'm working on the barrier. So this is why I like to use this even after a chemical peel.
And even, can you use our products even with the rosacea?
Yes.
And what's been your experience then?
Anytime I use a laser for rosacea, and in this case I use a combination of Nd:YAG to treat all the vessels which are visible, long pulse. I use an Nd:YAG laser short pulse, full face, to deal with the neovascularization or the inflammatory process. And then on top, I use a 1 or 2 passes of IPL. So this during the same session. After that, the skin barrier is a little bit disturbed. You know, I use 3 different lasers, or two laser and 1 IPL. So I like to use something which is, again, protecting the skin. In rosacea patient, the reactivity of the skin is highly pronounced. So if you leave them alone after a procedure like that without any proper moisturizer, they are, you know, they may be inflamed for a longer time. So they don't see the result immediately and they start to complain. So sometimes we also combine this protocol with LED. We use a sandwich technique. We use a 633 nanometers LED 20 minutes before the laser procedure, and the same red LED after the procedure, followed by Stratamed or better Stratamed because it's thin. I don't want to, the skin is not irregular. Stratamed, and on top of Stratamed, some spring thermal water, moisturization, and a moisturizing cream.
This leads quite nicely towards sensitive skin and the concept of finding a place where you can use it around the orbital regions, the nose, the mouth. Would you like to show the Stratacel video?
Yes, please. Can we have the video about the, let's say, post-acne fractional scar?
Oh, sorry, we've got A up.
Okay, fine,
Yes,
no problem.
Sorry, we'll get that one second.
Yeah, no, it's fine. Let's see.
In this case, we got 2 different areas treated differently with 2 different lasers. The periorbital area was treated with a CO2 full beam laser, and the fractional resurfacing was performed with the erbium YAG laser multipass. When you have a full de-epithelialization, that's you need to shrink the skin after lower lid blepharoplasty.
You will see that when we apply, at the beginning, the patient was kind of painful, the application. But when we form the film, you see I'm using the Q-tip applicator and the patient is not moving anymore, because it's a film forming barrier.
What do you think, Nino, about this approach?
It's a lot more robust. It's a lot more protective. It enters the pores and the de-epithelialized skin in a much easier way, and it's bacteriostatic, so it won't promote any infection, and it will enhance the healing. So I think it's a wonderful approach.
Leonardo, I see here you're going very close to the eyes. You don't have any issues with the application so close to the eyes?
I'm not scared because actually the consistency of this kind of silicone gel allows me to be very, very precise in the distribution. And you can see that the patient is comfortable even if I'm using an applicator, because the applicator is sliding over the surface. And if something goes maybe into the eye, there is no problem at all, because this is inert. So I try not to, but I'm not scared.
Here we are almost caressing the patient after the procedure. This is immediately after the procedure. Patients otherwise, they are very, very in pain if you do something like this.
And this is, you can see the patient 1 week post-op.
So to see, in this case, we were aggressive, but not that aggressive. Now I'm going to show you an aggressive case, which is acne.
So whilst we go to that video around acne, you were actually touching with your hands. Is it an uncomfortable feeling to actually, for the patient to have your hands touching them during this very particular early stage?
Once we first distribute the first layer of Stratamed or Stratacel. Stratacel, we use Stratacel, which was much more consistent around the eye because we use full beam resurfacing, and Stratamed all over the face. It's a very nice, even soothing effect for the patient. They immediately feel that the skin is less irritated. And you can notice that after we apply the first layer of Stratacel around the eye, she was a little bit uncomfortable. But then when I used, and the eye was completely resurfaced by the barrier, then she was much prone to accept my Q-tip applicator movement around the areas. So no at all. It's very comfortable for the patient.
And you seem to put quite a lot on. That's what you do initially. In the first phase, you put a larger amount on, and then what happens after that?
The importance of applying the right amount, which seems to be much more than needed, is one, to give the patient a longer autonomy. Second, to be able to resurface all the irregularities that I tried to explain in my presentation before, which happens to be after a resurfacing. So you don't see it, but the skin is not flat anymore. It's very irregular, so it needs more product. We can have the other video, which is the video that show you the post-acne. The post-acne, of course, these are the best patients because they accept any kind of aggressive treatment, but maybe their expectations need to be, properly evaluated because...
These are difficult cases because acne scars need to, for us to sculpt deeply, and these patients have a prolonged healing time, even if it's a fractional procedure. This is when we remove the wet dressing after 60 minutes post-op. And you can see the typical aspects of these patients. And this is the application. In this case, something really needed because the irregularity of the surface and the wound, that thermal wound we did, required this kind of thickness of primary dressing. This is 24-hour post-op. So it's very comparable to a full, let's say, silicone sheet. So when you remove the silicone sheet, the patients look like this.
And what is this white? Is this just gauze?
This is
not silicone.
No, that's just gauze. That's gauze. We after 24 hours, of course, we get some inevitable. We have some oozing, and we have some coagulation of the serum on top of the skin. So we need to clean it. I like to clean it.
So in that first 24 hours, that was not covered, was no secondary dressing, right?
No secondary dressing, yes. And this is very much appreciated by the patient because they can see through, because the advantage of this dressing is it's transparent. So they are not scared because I warned them before, and they can move. Due to the pliability of the silicone gel, we can really please the patient. The patient are happy because they don't feel this kind of pulling effect that is typical after this kind of procedure. What do you think, Nino?
I think the product, because of its robustness, its denseness, is very protective. And now you've de-epithelialized and heated up the skin to such a point that it's very vulnerable. And I think this particular product is a nice way to protect the skin, prevent infection, and to promote healing.
So Leonardo, this is still day one, and you're having a second application now after a cleaning.
No, this is after 24 hours.
Yes.
The skin is still oozing, and I like to apply more.
So, if you treat stretch marks, we have also it's a Strata mark, which is another silicone the Strat Pharma is producing, is a panacea to improve all the stretch marks. But it really helps to be used in conjunction with other techniques and to prevent stretch marks. There was recently published a nice paper with a lot of cases using Strata mark alone as a preventive measure, or Strata mark in combination of treatments compared to non-treatment, or compared to just the aggressive treatment that the doctor or the colleague wanted to perform to improve the stretch marks. Can I see the video? So how we treat stretch mark, we use sometimes, as in this video, a fractional radio frequency device, which is able to create the double effect, as I told you before, which is micro-perforating the epidermis, creating a
so this video is about stretch mark treatment with fractional radio frequency and 15% TCA chemical peel immediately after. Stretch marks are very difficult to treat, but with radio frequency we can have some good results. This is just cleaning and the skin, and it's with the radio frequency, the fractional radio frequency, what we do, we pierce the skin with microneedling, and we allow the electricity to travel in the dermis in order to warm the dermis and to create this thermal effect, which is going to be able to remodel the area. As you can see here, this is a contact procedure. We need to be in contact with the skin to press the microneedle into the skin. So it's a micro-wounding effect, but it's creating a lot of edema. It's creating a lot of redness, which is building up, with time. You can see that this surface needs to be protected with something, and nothing better than using a very nice silicone film, and this time we use the stretch mark prevention Strata mark, which is a silicone which has a different kind of consistency, and also stimulate the area to heal faster and to remodel better. What do you think, Nino, about this approach?
I think this is the perfect agent, the silicone gel for stretch marks. It has a consistency that will help promote the healing of the stretch marks after the radiofrequency treatment. But also, because you're using the 15% TCA peel, you've disrupted the epithelial border or bounder, barrier, I'm sorry. The barrier has now been interrupted, and this Stratamark is the consistency and the robustness of this particular product is just right for the combination of treatments that you just done.
And at this point, the patient is very irritated. They start to complain to the point that it's very irritated. So immediately after this maneuver, when you start to spread the silicone, they feel an immediate relief. And they like it immediately. It is very nice because this procedure needs to be repeated. So you need to give the patients some kind of comfort at the end of the procedure so that they can come back with more happy than being touched.
Well, there's a lot of erythema. So I think this Stratamark reduces the erythema of your procedure.
So, Professor, previously, and we've spoken about this in our travels, we would use in combination here in Australia things like bio oils and cocoa butters and pawpaw ointments. What's your experience with them, and how has Stratamark changed your decision making when treating stretch marks?
You see, everything in surgery and medicine goes most of the time by tradition. You learn at a university, your professor is using this kind of post-operative dressing, and you try to repeat it. And you repeat it, you see that it's working, then you use it. But again, I think that you need to engage, your brain to be a little bit stimulated by the new product and see if the new product is bringing you some better satisfaction to you and your patients. So I started to use in surgery a lot of Vaseline-based ointments, Vaseline, but again, I was able to obtain some results. Patient healed faster. They got better result than the dry dressing, of course, but it was quite, messy to work around. It was very difficult also to remove because the Vaseline is long-standing and it's the redness is there. So I thought, why don't move to a different dressing? You mentioned the oil. What is an oil? Oil is also a self-leveling kind of dressing, but oil is occlusive. So again, it's messy to use, and and if you combine with other substances, like you said, which is papaya or some extract, fetal extract, I don't want to treat my patient on open wounds with something that potentially lead to a allergic reaction. You never know. And when you combine different substances in one product together, which is responsible for the allergic reaction or the reaction, you don't know. So I like to use a monotherapy, which is one single substance. And this is single substance, if the single substance has a specific characteristic of being bacteriostatic, transparent, which is, let's say, inert, easy to apply and remove. The patient are comfortable, why don't use it? So I started, and I was much stimulated, not after surgery, but I was stimulated by my patient after resurfacing. Because after resurfacing, I was pleased, but not 100%. So I always have to fight against this kind of crust, against this kind of irregular healing, which happened to be in highly movable areas. I never got anything that was able to really please me. So when I came across this kind of silicone gel, really, it changed my life. and not only my life, but my patient life and my nurses. They like to treat with Stratamed, Stratacel, and all the Strata family. And even for the nurses, when they come from surgery, they are reluctant. You know, what I'm doing, you know, what I'm using this silicone for. So I try to explain. Teaching is the best information. And I think that now my nurses, they know perfectly what to do. And I just, you know, it's always a nice, pleasant surprise when I see my patient coming back with this kind of skin after aggressive procedure on the face or other parts of the body, thanks to this beautiful dressing.
One of the things that we haven't seen is that multi-layer rejuvenation. Shall we show the video of that now?
Oh, the multi-layer?
The multi-layer rejuvenation, the last video, please.
I think that we saw already. No?
This one here.
Ah, this one. Okay. So this is a combination of different laser and Q-switch laser.
Okay, the video is about multi-layer rejuvenation with the Q-switch 532 laser and photo peel. We are on the décolleté of a patient that's loved the sun too much. And this is the Q-switch, very gentle Q-switch, not more than 1.1 or 1.2 joule per centimeter square, 532 nanometers. And this is to remove just the superficial pigmented lesion like solar lentiginous, very well these extensive surfaces. So the silicone gel we use, it's again an excellent primary dressing because we don't need much. The patient feel comfortable immediately after this kind of procedure. And believe it or not, they feel an immediate relief after the application of Stratamed. Why? Because Stratamed is 100%, let's say, spreadable silicone gel, which is contouring or recontouring the epidermis, or the wounded epidermis in a excellent way. What do you think, Nina, about...
Well, I think you're right, because this is my favorite dressing. I do IPL, and we apply Stratamed over the area, and the patients immediately are more comfortable than when we did the IPL without using Stratamed. We sometimes didn't really understand what we needed to apply, so we would put a topical steroid, a relatively potent topical steroid, and Stratamed is just as effective, but I think it's more healing. It promotes healing better than a topical steroid. We've done one side with a potent topical steroid and the other side with Stratamed, and invariably the patients say they're more comfortable. There's less heat production. Their skin cools off more rapidly, faster in a day or two. There's less itching, and there's a visible promotion of healing and satisfaction by the patient.
As you can see here, at the end of the IPL, we did a chemical peel, 15% TCA, just as a finishing effect. And you can imagine that after this kind of micro wounding of the epidermis, we need something able to seal the epidermis from the environment. And nothing better than a good spreadable thin film of silicone gel.
So before you applied the Stratamed there, what cleaning protocol did you have? You cleaned what?
With just normal saline.
Normal saline?
Normal saline,
yep.
Yes.
And then Stratamed straight on top?
Straight on top, as you can see. And you see the spreadability is fantastic. And what it is very important to say that even if you touch the patient with your gloves, the patient tolerates that because the contact is not rubbing, is sliding.
So I think that after this series of presentation and after discussing the importance of this new product, which is not just a primary dressing. Again, talking about primary dressing, I think it's a little bit reductive. I think this is a film-forming, barrier-mimicking product which is able to resurface the skin in any kind of, let's say, modification of the barrier. Could it be after a procedure? Could it be after a inflammatory process, chronic inflammatory process? Could it be after a wounding that happened by chance, an accident? So I think that we have in our hands something which is really unique. And I think that in the future, this will substitute all kind of dressing. And even at home, to keep this for your kids. As when they come with a bruise, okay, use something like this. Not use, an antibiotic cream on top just because you have it. So it's there. It has a long shelf life. It's not nothing grows in silicone. You can keep it for a long time. And I think that this is the future of this wonderful family of products. And I think that I urge you to try the different layers I told you, particularly if you use the combination of actives and moisturization after that. So remember that if you put an active, put it immediately on the skin. Then allow the active to be absorbed and then put the silicone on top. Okay? If you want to give extra moist, you can put some spring thermal water and a mist of spring thermal water and silicone. Okay? Just to give the skin the natural barrier protection. When the silicone, the outermost layer of the skin, which is of the silicone, which is exposed to the environment, is drying, as you felt after the application, then you can treat this area like a normal skin. You can put some protection on there. You can put a moisturizing cream, anything, because the film is there. And I think that I'm convinced, I didn't do any study on this, but I'm convinced if you protect the film with the moisturizer, it stays longer than alone. Because the film disintegrates after 3 hours, as I pointed out with my measurement of the transepidermal water loss.
Usually clean skin after full ablation or after fractional ablation.
Yes.
So the question is,
Skin and then
the question is if I usually clean the skin after a full surface ablation or fractional ablation.
we usually use B10 and we don't clean after last pass. We apply it in order to
I know. So I like to clean. I like to clean because it's we have a lot of debris, a lot of dead cells there. So I like to clean with normal saline. I'm not irritating. It's already irritating at the end of the procedure. So I eliminate what is not usable for the healing process. And then on top, I put the Stratamed or Stratacel. Sure, yes.
question is from Adelaide, and they wanted to know two things. First one is the glue that you use during your procedure. Is it something special? And secondly, when you put your secondary wound dressing on top and you take it off, do you take off newly granulated skin after 10 days with Stratamed, or does it protect?
So the glue I'm using is called Mastisol. It's a glue that I discovered in the States 30 years ago. And I remember in Italy we were using the Stratacel without any glue. I said it was a waste of time and money because they didn't get any adhesion on the skin. I said, why using him? So when I went to the States, I noticed they was using this glue before. And believe it or not, the glue was produced in Italy. so the manufacturer was close to Florence and at Fernley Laboratories. Then after a while, he decided to move to the States, and now it's sold all over the world. So the brand name is Mastisol. And it comes also in sterile vials. If you want to, you break the vials and you just paint the skin. You allow the glue to dry. Don't put the sterile strip on immediately after because it doesn't work. So you need to have a sticky surface, and then you can exert, as I show you in my video. You can bridge the skin on top, so you have a nice approximation of the wound edges. After that, I use my secondary dressing, and after, of course, Strata cell or Stratamed, and I leave it on with undisturbed, as I said, for 7 days on the face, for 10 days on the back, on the chest, for 14 days on the legs. On the legs, always supporting stockings, always, even in a minute, kind of wounds, because I'm convinced that you need to take all measures possible to eliminate all the possible, let's say, side effects that can happen after this kind of procedure. And on the lower leg, there is always swelling. So with the proper support in stocking, a simple battle, let's say, strategy, they don't have any problem. So I like, even when I remove tattoos on the legs, I use that because they tend to swell. So with support in stocking, 2 days in a row, they go to sleep like we do sclerotherapy. Yes, the same thing. We do sclerotherapy, 2 days support in stockings, and then they remove it, and they work during the daytime until the next procedure. So I think this is a very important, let's say, way of thinking to combine all the possible protective and preventive measure to have the healing process under control, so that you don't have any surprises.
And in terms of the, when you take off your secondary wound dressing, are you taking off newly granulated skin with the Stratamed on top? No? Yes?
No.
No?
We don't have any if you have an open wound, I don't cover and leave it on for 10 days. If you have an open wound, which is an ulcer, we need to clean the ulcer and cure also what is underneath the ulcer. If we have a chronic venous insufficiency, it's not that we use Stratamed or Stratacel, we're going to improve and we're going to heal the ulcer. We need to treat the underlying disease first. And of course, we can use in combination with the other treatment. So I'm not disturbing at all the granulation tissue with this if I use it very often, because I kind of protect the granulation tissue from being disturbed too much from other kind of dressing.
And now questions from the field. If anyone has any questions, by all means, please, put up your hand. No questions? Well,
yes.
We have one question here at the front, please. Dr. Ranker.
I'm interested, how would you treat sebaceous hyperplasia with photonal laser? I have only PSO3 handpiece and R11. I don't have any other scanner or the other handpiece.
Well,
and what is the best setting?
The best of the best.
Thank you.
Well, sebaceous hyperplasia are difficult lesions to treat because they tend to recur. There is no treatment which is final. If you're too aggressive, you create depression because, of course, the problem is in the dermis and not superficially. So what I'm using, my strategy is to use electrical needle, like a hyfricator with an epilating needle. I pierce the skin several times, and then I use a chamber comedone extractor, express the content out. And of course, I'm not saying my patient, I'm going to cure you, I'm going to get you better. At the end of this, I use an Nd:YAG laser, 4mm spot, long pulse, let's say 35 millisecond, and I would say 30 joules, 35 joules, 1 or 2 pulses. Why I'm using that? I'm going to use temperature on a pre-wounded area. So I enhance the, let's say, inflammation or the shrinkage of the cells, because I'm using the radio frequency first, and I do a preliminary damage, and I do a finishing damage with the Nd:YAG, which is, in my opinion, a little bit better than using radio frequency alone. On top of that, I use the dressing that we discussed, and I have beautiful results without any depression. If you try to vaporize the, this lesion with the erbium-YAG laser, no. Because you vaporize the skin, you want to eliminate what is underneath, and you end up with some depression, which is not good for the patient that comes for a cosmetic, improvement. So what we use, for example, in xanthelasmas. Xanthelasmas, we use the erbium, or recently we started to use a Q-switch 1064 in ablative mode, which is less thermal, has a less thermal effect. We use a photoacoustic effect to fragment the areas. It's very nice. So try it if you have the Q-switch laser. But don't be aggressive. Don't think that you have in your hand, you have a beautiful wavelength. You have a beautiful system, but if you use this wavelength to sculpt, this sebaceous hyperplasia, you may end up with depression. Don't use it. My pleasure. Yes, please.
There was a lady you were showing had a lot of media around.
Yes, yes.
There was a lady in your presentation with
Was
a
a
lot of
guy, yeah.
media around the eyes, periorbital region. How did you treat that woman?
In this case, we have a special handpiece by Photona, which is able to have a 0.2 millimeter spot. So you just pinpoint to each milia, pop, pop, pop. So it's a milia hunting, and then you use a full resurfacing, full beam resurfacing of the area, and then you use on that a comedone extractor, tuck, 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 and you eliminate that. So this is the procedure. And then, of course, the primary dressing. Yes?
I have another question. Keloid in the earlobes.
Uh-huh.
Do you have some effective treatment you've tried before? Keloid in the earlobes.
Well, treating keloid is always a problem, as you know. In stable keloid, I try to excise the keloid, the hatch technique. So I detach the keloid from the skin. I leave one of the skin, one of the hatch attached. I remove the mass, and then I inject some triamcinolone acetylenoid, 5 milligram per mil all over, and then I close with the skin all over. Then we use the primary dressing again. In case of relapse, we suggest radiotherapy. So these are the two things. When the patient is healed in keloids of the earlobe, we give this formula, which is 3 days in a row, strong steroid, clobetasol, twice a day, and 4 days in a row, imiquimod, followed, by strata, and followed by a moisturizer, twice a day. So why we use imiquimod? Because imiquimod has an anti-neoangiogenic effect. So we know that keloid is highly vascularized. They tend to get back for that, and we have good result with that formula. Even in old scar, hypertrophic scar. In other keloids, we inject triamcinolone acetylenoid, 10 milligram per mil. But if you inject without preparation, we don't have enough room. This solution go. So you struggling, and of course you don't have any room. So the secret is you perform local anesthesia, then you use a 25 gauge needle, and you create micro tunnels in the keloids. You fragment mechanically the keloids in order to create a spongy effect. Don't be scared if you see, blood coming out, of course, it's normal. Don't be scared if you see the keloid turning, kind of bloody mass. Don't pierce the skin, work under the skin, like a liposuction, but instead you do just tunnel in the keloid. You massage, and you feel that you're able to flatten the keloid just mechanically. When the keloid is pre-treated like that, then you inject. You inject the triamcinolone, and you massage in order for the diluted triamcinolone to travel in all the tunnels you created. Then you use a compressive dressing, strata, compressive dressing, and you allow to stay for 2 days, 3 days, and then you continue with the protocol. When they are healed, because they may have some holes, then you start with the anti-neoangiogenic protocol I told you before, until the next session, which is usually performed after 30 days. Okay.
Any other questions from the field? Well, Leonardo, thank you so much for an amazing talk. I'd like what you did last time, which was quite amazing. You brought the idea of the full circle. So if I could ask you, you started off with the circle of the laser, but the second half of the circle is in the wound dressing. Please, close the meeting with that great story.
So, again, every time I give a lecture at the university or when I have students over to the clinic, they are all interested in opening the circle. What do you perform for this? How come, what are the parameters? What is, your technique? And so this is opening the circle. So they see the way I perform, and then they take a lot of notes, okay, and they go back home to try to repeat that. I said, but don't rush. I said, this is just opening the circle. Wait, because you need to close the circle completely. Otherwise, if you don't close the circle and mean that you don't do the primary dressing and you send the patient home, you need to to follow the patient until it's perfectly healed. So this is closing the circle. So this is the take-home message. Don't think that if you have a good laser like this one, or you have a good technique in your hand, you are successful because you know how to perform the technique. You are successful because you're able to close the circle properly. And when the patient feel that you're taking care of him, of her, until the equilibrium is reached, then you have a friend. You don't have just a patient. The patient feels that you care for him, or for her. So it's very important to be precise and to have this kind of approach. The patient is happy, feels that you are caring for him or her. Thank you very much.
Well, thank you very much, Professor. Thank you. Ladies and gentlemen, that brings us to the end of our meeting tonight, and I'd like to thank our co-sponsors, Fotona, and in particular, Innovative Medical Technologies, Paul and James, for bringing up what is an amazing apparatus up here that has multiple uses and multiple ways of being able to help your patient. And I do stress, please, go up and speak with Paul or James. They'd be more than happy to talk to you about how Innovative Medical Technologies can help you. With regards to Stratpharma, Stratpharma would like to be able to partner and help you. We have the opportunity, as you've heard, to provide the beginning of the circle with the Fotona laser and completing the circle in terms of wound dressings, wound recovery, and providing a barrier that is mimicking the skin in many of its ways. And we'd like to be able to offer you tonight, in your bags, we've got a special order form, which is a Professor Marini special. So we've got 3 different deals. We've got the 15% deal. We've provided you also with a deal too, which is 12.5. If you'd like to dip your toes in, we've got the 3rd deal, which provides you with a 10% discount. So please, we've only given this out for 2 weeks, so I do stress, if you are interested in being able to try the Stratacel, try the Stratamed, or try any of our other products, please fill out the order form and pass it on to our amazing team, which is Ian and Liz. Professor, before we finish, please come over, because one of the things that we've had a pleasure of doing is driving all the way from Noosa down to Brisbane, and I got to spend some time with Danny, Danny, please come on up. Come on up. So Danny Jones, our WA sales manager, and when we were discussing with him, we found out that the professor is not only a professor of skin, he's a professor of history, and in particular military history. So we went to a shop today, and we were looking around, and we wanted to be able to present you with this. And I don't know if you can get. Whoops.
Oh, that's not handy.
Okay, now just broke. No, it didn't. So we wanted to be able to provide him with a small type-in from the, it's the Australian Infantry Force, Imperial Force, Australian Imperial Force from World War II. And I hope that you enjoy this gift from Australia and from all of us to all of you. We thank you so much for coming, Professor Marini.
Thanks. Just thank you. Thank you.
Any questions? My team is here to help you. But until then, have a good night, and I look forward to meeting you in the field very soon. All the best.